Sandie Thomson here from the Foundation and Gecko, and welcome to our first endoscopy meeting of this year. Again, we are sort of up and down with COVID as usual, and we do hope that this year will give us a little better platform to develop things and to get you all involved from as hubs and spokes and presenting cases. So today we thought we would start with a case presentation, and my colleague who runs one of the regional hospitals surgical services at Victoria Hospital here in Cape Town, Jeremy Plaskett, is going to start, and he's going to start with a case that will lead into my talk, and we'll discuss some principles then. So I hope you enjoy the offering today, and as I say, we'll start with this case-based presentation. And Jeremy, if you could now unmute and share your screen, and please deliver your talk. Thanks.
Thank you, Professor Thomson. Hi, everyone. To set the stage for Professor Thomson's talk on air in the biliary tree, I'm going to present a case which we had at my hospital last year. It was a 58-year-old male known with hypertension, also an ex-smoker, who presented to our emergency center with a 1-year history of chronic right upper quadrant pain. He had actually had an ultrasound the year before, which was reported to be normal. He was then admitted in November of last year with increased severity of the same pain, as well as vomiting, fever, and a tachycardia. On further inspection of the vomitus, it was found that he had this hard gallstone-like material in his vomitus. And on further inquiry, it was uncovered that he had actually presented 3 times to the EC in the last week with this history of worsening right upper quadrant pain. It was then associated with fever and rigors, as well as shortness of breath. He had an elevated white cell count. His renal function and electrolytes were normal, and very slightly deranged LFTs. His venous blood gas showed that he was dehydrated, as well as a metabolic alkalosis from his vomiting. And a chest x-ray showed that a pacification on the right side of his chest, which was diagnosed as a pneumonia. And on these previous visits to EC, he was discharged with a course of given stat IV augmentin and discharged with a course of oral antibiotics. We were eventually called to assess the patient on his 3rd visit, and on our abdominal examination found his abdomen to be distended, generally tender with guarding in the right upper quadrant. And like all good surgeons, the first thing we did was to book a CT scan. I'm going to scroll through the CT scan and let everyone see if they can spot the abnormalities, and then afterwards we'll go through a few of the frames just to highlight them. This was his abdominal CT scan, the portal venous phase. Okay, now we're just going to go through a few of the highlights of that CT. The first thing at the beginning you would have hopefully noticed is the pneumobilia, and that's, we can appreciate here, the intrahepatic biliary ducts have some air locules in them. Going a bit further down, we can see there's also air in the extrahepatic biliary tree, and you're starting to see it at the dilated duodenum there, immediately adjacent to the liver and bile ducts. Here you're appreciating that there's small bowel dilatation and small bowel obstruction with some pneumatosis in the wall of that jejunal loop. Here you can see that there is some small bowel which is still collapsed, suggesting that there is a transition point and there's a mechanical obstruction at some point in the small intestine. And on this slide, in the center of the abdomen, you can appreciate that there's some small intestine which isn't enhancing as well as the surrounding bowel. It's a ischemic and necrotic intestine, again with air in the wall and probably also some extraluminal air. And then immediately above that, on everyone's top left in the peritoneal cavity, in the lumen of that bowel, you can see a gallstone, which is enhancing the same as the wall of the small intestine. On the coronal sections, this is showing a shrunken, thickened gallbladder, which you would expect with repeated bouts of cholecystitis. And again, you can see the dilated loops of bowel. And here, this slide's actually demonstrating the fistula. You can see air tracking between the thickened gallbladder and the duodenum, which is immediately next to it. So that's actually showing the biliary enteric fistula. So following this, we took the patient to theater. Intraoperatively, we found an inflammatory mass involving the gallbladder and the second part of the duodenum. There was, it appeared to have sealed off, and this was confirmed by passing a gastroscope into the abdomen and insufflating the stomach and duodenum with some air. No air leak was found. And we proceeded to just do an ementopexy on top of the inflamed gallbladder and duodenum to make that seal a bit more robust. There was a necrotic perforated segment of jejunum about 30 centimeters long, which was 100 centimeters from the DJ flexure, with small bowel content contamination of the peritoneal cavity. This area of small bowel was resected and anastomosed. And then distally in that segment of small bowel, we found a large 3 to 4 centimeter gallstone lodged in the jejunal lumen with a clear transition point in the dilated bowel and collapsed bowel distally. That was the gallstone we removed from the jejunal lumen. It was about 3 to 4 centimeters. Post-operatively, unfortunately, the patient didn't do very well. He immediately required ICU, had ongoing sepsis, which prompted a relook laparotomy on day 2. His anastomosis at that relook was found to be intact, although the other findings suggested that he had developed intra-abdominal sepsis with purulent fluid in between his loops of bowel. He was washed out and taken back to ICU. Developed worsening sepsis then on day 4, eventually requiring inotropes, and demised the following day from overwhelming sepsis and multi-organ failure. Just a little bit about the diagnosis that we're presenting today. It's gallstone ileus is an uncommon cause of small bowel obstruction. It's quoted to be about 1 to 4% of small bowel obstruction overall. However, amongst older patients, it does play a more prominent etiology in small bowel obstruction. It was first described in 1654 by Thomas Bartholin, who was a Danish physician. And the diagnosis really depends on this triad, which is Wrigler's triad of pneumobilia, which we showed on the CT scan, or air locules in the biliary tree, small bowel obstruction, and ectopic gallstone, which is most usually found in the right iliac fossa in the area of the ileocecal valve. The pathogenesis involves essentially chronic cholecystitis with repeated bouts of cholecystitis eventually resulting in adhesion of the gallbladder to the duodenum. It can also adhere to the stomach or colon, and you eventually get, with ongoing inflammation, a fistula developing between the gallbladder and the lumen of the bowel, usually the duodenum. You then get a passage of gallstone from the gallbladder into the GI lumen, and this usually becomes impacted at a narrowing in the gut lumen, which is usually the ileocecal valve. In our case, it was the jejunum. If it becomes impacted in the stomach or duodenum and you get a clinical picture of gastric outlet obstruction, it's known as Bouveret syndrome. As I've already mentioned, the diagnosis is made by demonstrating Wriggler's triad. We usually rely on some sort of imaging to show this. Plain film might show air in the biliary tree. It will certainly show the dilated loops of small intestine and small bowel obstruction. Ultrasound is obviously useful for demonstrating gallstones, although in our patient, he hadn't had a normal ultrasound the year prior. And just to remember that the minority of gallstones are actually radio opaque, so they don't light up on the CT scan. It can sometimes be quite difficult to find the gallstone that's actually lodged in the lumen of the bowel, but it's usually going to be found at the transition zone. So the gold standard, as we demonstrated in our case, is obviously CT scan. In terms of the management of this condition, it has been described using more conservative measures. If there's a communication into the colon, there are cases where they've dislodged a stone with endoscopy. However, the mainstay is usually surgery. The surgery essentially involves 3 different procedures: an enterolithotomy, a cholecystectomy, and then some sort of management of the fistula that's led to the gallstone ileus. So this can be performed as a 1-stage, a 2-stage, or a 3-stage procedure with, in the case of a 2-stage, the cholecystectomy and fistula closure following initial operation of about 4 to 6 weeks. There is a series and showing slightly higher mortality in a 1-stage procedure, 16.9 versus 11.7%. Bearing in mind that the unaddressed biliary fistula may actually close spontaneously with time, but the risk of waiting with that comes the possibility of recurrent cholangitis, sepsis, and even a recurrent bout of gallstone ileus if another stone should pass from the gallbladder into the lumen of the gut. You would have to be incredibly unlucky, I guess, for that to happen. And that's gallstone ileus.
Thanks very much, Jeremy. Thanks for that. And it's a very nice lead-in. I'm sure there are some queries and questions, so please, if you could post them on the chat, because I'm going to try and put, obviously, gallstone ileus is one of the causes of air in and around the biliary tract. And there are, of course, several others that I think are important. And I'm just going to go through some of these clinical scenarios that I've encountered during my practice. And then I think we should share the floor and see exactly what some of these management problems are and how you have solved them or might consider solving them. I'm going to share my screen now. Yeah, so I'm going to talk, Jeremy's led into it very nicely, and as you will see, there are some really very problematic causes of biliary error. And I'm just going to try and outline an approach to these findings when you come across them. And unfortunately, usually they're quite rare. So you have to keep your wits about you when you come in touch with them. So you heard Jeremy, obviously it's a sign, it's an imaging sign, because really we do not know, we do not really encounter it in the course of the clinical examination and investigation. And of course, obviously for many, many years, all that we had was plain radiology in the old days, supplemented by ultrasound, and obviously air was the enemy of the ultrasonographer in the old days. Now, of course, it's relatively easy to distinguish. And then CT scan. So there's absolutely no doubt what Jeremy was saying is that, surprisingly, in about 40% of cases, the abdominal X-ray will be abnormal when it's present. It's a question of whether you look in the right place, and it may indeed be very, very subtle. Then abdominal ultrasound is actually better. Again, that depends on the experience of the operator, and again, the context in which you might or might not see the air. But CT scan is really very good at picking it up, and you saw an excellent example from Jeremy as to how accurate CT of the abdomen is in detecting biliary air. And I'm also going to talk not just about pneumobilia, because there are other circumstances where you see air in the biliary tract and around the biliary tract, which are equally pose separate clinical problems. So this is just sort of a summary of what you can sort of put into these boxes. And one of the things that you should think about if you see biliary air or air around the biliary tree is, has there been prior interventions? If there is air in the biliary tree, that usually means that there's been an ERCP, a stent, a stone removal, sphincterotomy, or especially in the old days, and if you practice in areas where you have a large hepatobiliary specialist practice, then you will also see patients who have biliary enteric anastomosis.
Sandy?
Yes.
We're not seeing the slides moving. You're not in slide mode.
It seems as though they're moving for me.
Okay, it's just on view on my side.
Let me stop the share and share it again. Forgive me.
Okay.
Can you hear that share? Can you see it now?
It's coming up.
Have you got it now?
Not yet.
No, no, it seems to be sharing at my side.
Okay.
I mean,
Up now?
does it come now?
Yes, it did.
Are we good? Okay.
Yeah.
So I'm not exactly sure how far we got, but basically I was trying to emphasize that we need to think about prior intervention when we've done ERCP or when we've done biliary enteric anastomosis. And then obviously there can be the iatrogenic problems around perforation, either into the retroperitoneum or free perforation into the abdominal cavity. And then sometimes these things occur spontaneously, as we've heard of. That can be essentially from pathology, which has eroded and caused it. And again, you can see there's a host of causes there. And also worms, especially in young adults and in children, can also lead to a paralyzed sphincter, which allows air to egress in and out of the biliary tract. And then, of course, you can get air around the biliary tree in emphysematous cholecystitis, in biliary abscesses, and also when you get gas-forming organisms in the biliary system, again, usually related to prior intervention or intrahepatic sepsis. And the other thing is that you need to sort of have an awareness of whether the patient is well, sick or very sick, and whether they're jaundiced or have cholangitis. And again, these things, as you will see, will factor into how these patients are managed. I have a few clinical cases that I'd like to share with you, and I've called them the good, the bad, and the ugly. This movie was made as one of the dollar movies. It was the actual climax of the dollar movies, and it was called the Italian Spaghetti Western. It made Clint Eastwood, who now is certainly older than me. And of course, there was Lee Van Cleef, and Eli Wallach played the ugly. So I'm going to show you some examples of the good, or reasonably good, the bad, and the ugly. First, the good. Here you can see an example of biliary air highlighted with the arrow. And this is from a prior supraduodenal choledochoduodenostomy. This used to be an operation that was widely practiced in the days before ERCP for patients who had stones in the gallbladder, and was an effective operation. But obviously its patency was mirrored by the fact that you could see lots of free air in the biliary system. Here you can see a patient who's not only got free air under the diaphragm, but they have air in the biliary system. Again, here the settings are highlighted to be able to show it. And in this occasion, this was a perforation, obviously anterior for the perforation of the duodenal ulcer, but it had also penetrated into the bile duct, hence there was air. And generally, when it's associated with a perforated ulcer, there's little that needs to be done about it other than to make the observation. And again, usually your focus is only on fixing the perforation and the contamination and not doing anything to deal with the biliary system. And that management can usually be expectant. It may pose problems if you encounter it with bile in the duodenum and the posterior ulcer. And then it may be problematic to deal with, especially if you have to do a gastrectomy of some sort. However, that's for another day. This is another lady who, again, had one of these operations called a choledochoduodenostomy, where they anastomose the top of the duodenum to the bile duct. And in the right-hand corner, you can actually see the lumen. And the ERCP has actually got a balloon through that hole that you can see there. And it is highlighting the biliary system. You can see it's a mixture of air and contrast from that. And of course, this was freely draining. And it didn't really explain this lady's symptoms because she was having recurrent bouts of fevers and chills. And what in actual fact had happened was that she had stones in the distal part of the bile duct, so-called sump syndrome, a bit like the U-bend in the toilet. That's where all the bad things can hide. And by simply removing the distal stone through the native ampulla after a sphincterotomy, this lady's problem was solved. They had been considering doing an open operation for this lady, but someone had placed a very big mesh across her incisional hernia from her original gallbladder operation, which meant I got involved to try and remove the stone from below. Of course, there are some interesting things that you can see. This was a gentleman who completely confused us when I was starting an ERCP service up in Pietermaritzburg. And we had an uneventful placement of a stent for a patient with a malignant obstruction. And then at the end of the procedure, he complained that he had a funny sensation after we woke him up around his scrotum. And indeed, he had a huge emphysematous scrotum, which took about 3 days to dissipate. Again, he was perfectly well, and it highlights the problem with retroperitoneal perforations, which I'll show you another example of. Now we're moving to the bad, and you heard of Jeremy's outcome. Jeremy's case is quite unusual in that the classical patient who gets gallstone ileus is in fact the old lady with no scars on her tummy. If you see small bowel obstruction in her, you should be really looking in the top left upper quadrant for the biliary air, because that's the giveaway. And only occasionally will you see the actual gallstone. All you will get is the small bowel obstruction that you see here. Again, usually the stone is large, and actually the narrowest part of the gut is actually the midpoint where it was part of its rotation to the umbilical cord. So most often it impacts there, and that's the problem that happened with Jeremy's case, is that impaction causes necrosis, and then sets this whole thing in motion with free perforation. And I think that the fact that it had perforated and they'd been observing it for so long was really what led to his death. If he had been dealt with at the stage where it hadn't eroded, then I think he would have had an uneventful post-operative recovery. I must admit, I've seen 3 of these in my time as a surgeon. The very first one, I was a registrar, and I told my boss that I had this patient with gallstone ileus. I'd heard of it, but I didn't know what to do about it. And he said, "Rubbish, I'm coming to see the patient." And true enough, it was in fact a gallstone ileus. But the other 2 that I was involved with were both similar to Jeremy's. One had a satisfactory outcome, but the other also, because of delay, led to huge problems with metabolic and septic complications. Of course, this is the other complication that you can get. We saw the benign free air from the scrotum, but this is now the kidney highlighted during the procedure. And in fact, I've seen this twice in my ERCP career, where you can clearly see the kidney outlined. Usually these are a result of sphincterotomy, and they usually can be managed effectively by non-operative means. Provided the biliary system is drained and they're not jaundiced, then it's quite reasonably safe to do this. However, if there is an instrumental perforation, i.e. the duodenoscope goes through the duodenum, then in my view, it's best to fix this surgically, though there may be a few enthusiasts who can do that with one of these Ovesco clips. But I think you need to be very cognizant of that. And of course, when patients with ERCP go off, the other diagnosis is pancreatitis, which is much commoner. And it's a really prudent thing to do an early CT scan if your patient post-ERCP is not recovering as you would expect. And it can help you to manage the patient effectively. What about the ugly? Well, here you see a case of emphysematous cholecystitis. And again, these patients are usually elderly females, diabetics, and they have gas-producing organisms doing this. And this is Clostridia perfringens usually, but it can be other organisms. And usually they're very sick. Again, you can see how the signs are subtle on the plain radiograph, but much more problematic, or much easier to see on the CT scan. Again, obviously, the treatment for this condition is to take the gallbladder out. And if the patient, again, survives on how systemically ill and septic he is, but obviously you must deal with the septic foci. This is a a very sad case that was the reason that I got involved in setting up the service in Pietermaritzburg in Durban. And this poor lady, she was about 34. She'd been seen on 4 occasions with symptomatic gallstone disease, it sounded very much so, at different healthcare facilities for over 6 months. And then she presented to Gray's Hospital, the tertiary hospital in Pietermaritzburg, in septic shock. And I hope none of you ever see an X-ray, 2 X-rays like this, because she's got a full house. She's got air in the biliary tract. She's got hepatic abscesses. She's got air in the IVC and in the portal vein. And she's developed necrotizing gastroenteritis. So there's free air in the wall. I'm not quite sure how she managed to get to the CT scan, but she did. But that was the last event in her very sad clinical course. And of course, the cause of it was 2 stones in her bile duct at postmortem. So it's very sad, and I hope you never have to see any radiographs like that. So she had acute ascending suppurative cholangitis, and I think these types of patients, we don't know if they exist in sub-Saharan Africa, but certainly the ERCP services are not as well developed as we have. And I think this would be a very good thing for us to try and help individuals to develop their ERCP services in sub-Saharan Africa to avoid what is an entirely avoidable complication of choledocholithiasis. So I just want to bring you back to exactly what you can do with these various sources of air in and around the biliary tree. As I said, you need to find out, is the patient well or jaundiced? Is the patient obstructed? And again, by appropriate investigation and dealing with any element of obstruction, you can usually defervesce the system into an elective situation. Obviously, when the patients are very sick, you have to decide whether or not they need an operation, or whether they should have an intervention designed to improve the sepsis. Again, these are the combinations that you see, and I hope that they've added some insight into how these are encountered in clinical practice. And we would be very interested to take your own inputs regarding these conditions. Relatively rare, but nevertheless, you need to think about them seriously to avoid catastrophes. Thank you very much. So I'm happy to take any input.
So Sandie, there have been some questions in the chat which have been answered by Jeremy. Perhaps Jeremy could repeat the question and then answer the question.
Sure, thanks, Chris. Yeah, the question was with regards to the first case, that what was the explanation for the opacity on the first chest X-ray? And I think that was an infiltrate in the lung, which was probably just a reactive thing to the mischief that was happening below the diaphragm on that side. You quite often see a pleural effusion or something with any chronic, be it pancreatitis on the left or biliary pathology on the right. I think he probably wasn't ventilating particularly well with what was going on under his diaphragm, and maybe did just develop a mild pneumonia on that side with that lung infiltrate. The problem was that that became the primary diagnosis and that everyone focused on. And I think that was used as a pathology to explain his right upper quadrant abdominal pain, which you sometimes get with a pneumonia, his raised white cell count, his fever, his rigors, and sort of took our attention away from the abdomen until we examined him properly and sort of looked for this pathology more actively.
Yeah.
Then how and why was the patient missed with all those visits to the emergency rooms? What was the initial doctor supposed to have done given the vomiting of gallstones? The vomiting of gallstones was actually only volunteered much later. And he very proudly on his most recent visit to the EC showed us these stones, because the EC doctor actually phoned me and said the patient's vomiting gallstones, and my reaction was quite similar to Prof Thomson's. I said, rubbish. Those can't be gallstones. And lo and behold, they were gallstones.
But I think that's when the penny dropped. And unfortunately, the only thing that would have got him there sooner, because in our ECs, unlike in America and in Europe, the CT scan isn't used as a triage tool. And obviously you would pick up the free air there very easily. And again, you saw excellent demonstration of all the aspects of the condition, that in the old days, they only had a plain radiograph to see. So you definitely had to have your wits about you. Again, traditionally, it's a single stone that impacts. So again, sort of it's your case is definitely male, and vomiting gallstones isn't generally part of the scenario that I've seen. So again, you're probably correct in telling the intern that perhaps he was barking up the wrong tree, but obviously he wasn't.
Sandie, there are a couple of more questions. Are you seeing them in the chat?
I've got, oh, sorry, I'm looking at the participants. Let me just have a look there. Yeah, I think, so there's a question about emphysematous cholecystitis and whether percutaneous cholecystostomy would be an opportunity there. I think absolutely not, because they've got perfringens infection. So you need to deal with that. And again, it may also be acalculous. It may not necessarily be calculus. So I would definitely say that it's one indication that there might be a case report about it, that it would be a dangerous strategy. I think if you see air around the gallbladder, you should make a plan after initial resuscitation to take the patient and take the gallbladder out, whether you do it laparoscopically or open. The thing is, it's generally speaking, it's the two cases I've dealt with, then it almost falls out of the dissection because the bugs have caused the sort of interface to occur. But it's very inflamed and bleeds like nobody's business. So I would go for operation.
And Sandie, there's a question on what caused the perforation that led to the scrotal air.
Well, there's no doubt on retrospect when we looked at the ERCP pictures that there was a retroperitoneal perforation, and exactly how it tracked there, I really don't know, but it was tenuously related to the ERCP, so we couldn't explain it in any other way. And the patient was completely well. That's the other thing. I think it's very important, especially when you see pneumobilia, to ask the patient, have they had a previous ERCP, or has a surgeon been operating on them for a biliary problem? Because they are usually well, unless they're associated with recent interventions. And they generally need very little done to reassure the patient.
We quite often see emphysematous scrotums after patients have a TEP or a laparoscopic inguinal hernia repair. And what happens there is the air tracks in that fascial plane pre-peritoneal, and we warn it's one of the things I warn all the patients of. Some are pleasantly surprised, others are horrified when they wake up with a big scrotal balloon under the sheet.
Yeah, there's a question here about the size of the stone. Exactly what happens is usually there's a cholecystoduodenal fistula, and a large stone usually erodes through that fistula. And that's why it causes the obstruction, because it's big. And usually they're cholesterol. So you don't, unless you see the actual outline outlined by some air, they're not generally, they're usually large cholesterol solitaires. They're not radio lucent. So in CT, they don't have any calcium in them, or usually not. So again, you're looking for some contrast around the stone to be able to see it, or its density.
Please unmute and ask questions if you feel so. You don't need to go through the chat. Edward Jonas, any comments from you? Just make sure that he's not sleeping.
No, I'm not. I think it's a couple of the caveats that you run into when you're dealing with these patients, and often a diagnosis that you don't necessarily think of. And I think the example that Jeremy gave was just demonstrating that. I would just like to add on to what Sandie said in terms of percutaneous drainage of patients with a cholecystitis. It's a good bailout option when you're dealing with a patient with a gallstone obstruction. In other words, a gallstone impacted in the cystic duct and eventually causing a purulent cholecystitis in Q1. But it's really a bad option if it's a acalculous cholecystitis, or if it's a gallstone cholecystitis that has progressed to the point of an emphysematous cholecystitis, because what makes the patient really sick is the necrosis of the gallbladder wall, and the gallbladder as it is not salvageable. So if it had not perforated yet, certainly a percutaneous drain is going to facilitate that and make the patient even more sick. The question about the retroperitoneal air, I think if we routinely do CTs on patients with ERCPs, we will be surprised to see how often there will be air in the retroperitoneum. Especially if we sort of keep the finger on the button. Usually not a very big problem, especially if you use CO2. And I've made an argument for that, and I can really sort of campaign for that. That is, if you get a retroperitoneal perforation after an ERCP with a significant amount of room air in there, that room air is going to be there for 3 or 4 days, keeping that cavity open and allowing for juices to collect there. If you use CO2 and the same thing happens, the absorption of CO2 is, I think, 160 times quicker than room air. And that cavity is likely to collapse within some hours. And I think the outcomes, to my knowledge, there's no studies about that. But I think it's one of the endoscopic investigations, probably together with the small bowel investigations and colonoscopy, where, if possible, do not perform any ERCPs without CO2. There were another few questions here, Sandie, that I'm going to put to you. Any tips for endoscopically managing Bouveret syndrome, if we ever see one?
Well, unfortunately, Jake Krieger is the expert on Bouveret. I've never seen one, but I really, the trouble is these things are so rare. As I say, I've seen 3 gallstone ilices in my, I'm touching on 70 now. So they're not 2 a penny. And when you come across them, they're usually in advanced inflammation. And again, you should remove the gallstone and fix the obstruction. And my advice is not to do anything about the fistula at all. Manage it expectantly. You do have tools that can help you to fix that now, and send it to somebody clever like Ed. If once you've taken the obstruction away, if you think they need their biliary tract better drained or the gallbladder out. That would be my advice. And I like doing RCPs, or at least I used to.
And then just another question here, any possibility or experience with a sigmoid diverticulitis and pneumobilia? No liver abscess, coming from Bongani Shabango. I don't know, Bongani, if you want to elaborate on that. It's probably based on an interesting patient you had, I guess.
You're welcome to unmute, Bongani, if you want to speak. I think I didn't address portal pyemia, but obviously portal pyemia is another source of gas-producing organisms in the biliary tree. And again, once that mucosal barrier is broken down and you've got bugs there, you can get air. So again, for me, it's obviously source control. So that would be one thing that one would think about. And again, air in the biliary tree is, if it's got there from somewhere else, it's probably not that important. It's the cause of it that you want to get to the bottom of. And that would be my advice. I've seen portal pyemia and infection related to intrahepatic stones and ascaris. I actually haven't seen it from
Bongani did unmute. Do you want to unmute again, Bongani, and any questions or further comments?
Thanks, Prof. I've had a patient with a diverticular abscess, about 3 centimeters in size, with a pneumobilia. And we're really convinced it was as a result of the sigmoid diverticular abscess. But we couldn't explain how he came about to have the pneumobilia. Thanks, Prof.
Again, obviously, it depends how systemically. Usually, patients with portal pyemia and gas-forming organisms are very, very sick. But I suppose, just like you can get a diverticular perforation that just has air in it and no purulent material, or it may be possible, but that isn't the mechanism that the air gets into the biliary system. It has to come from the portal vein in my mechanistic thinking of it. So I would be very wary that she might get another episode of portal pyemia if you don't deal with that. It would be tricky for me. Did you drain it percutaneously?
No, Prof. We were convinced the size was too small. The CRP of the patient was 310, but it dropped within 3 days of antibiotics to 110. So he was managed conservatively.
But it was a male, yeah?
It was a male, Prof, a 74-year-old male.
Yeah, maybe sounds like a reasonable course of action, but again, one would just be slightly concerned that it might misbehave if he has another episode, but maybe he won't. The tendency for that type of diverticular disease without that complication would definitely be to observe it and see what its natural history was.
Okay, thanks, Prof.
I hope that's partly answered your question at least.
Yes, Prof, thank you.
There's another question, Sandy. In the past, the patients that had choledochoduodenostomies, how common were problems related to enteric reflux, and was the risk of cholangiocarcinoma clinically relevant? Is there any place for hepatico-choledochoduodenostomy currently?
Well, it was a solution for patients who probably had a few stones remaining in the distal end of the duct. It was very popular because you didn't have to use cholangiography. In the old days of cholangiography, we had to take actual static plates. We had them in a thing like a pizza oven that went under the table. And surgeons didn't have the patience to do that. So they just did a choledochoduodenostomy. So I would have said in the 60s and 70s, that was a very common operation. And in theory, it might give you more biliary reflux, but remember the pylorus is intact. And again, I know of no real problem with these causing cancer, because if the hole is big, we used to have a rule that the bile duct had to be 2 centimeters at least in diameter, and you had to make the hole like a diamond. So that the big thing was, if you did it on a small duct, then those were the very patients who got into trouble, because they developed a stricture and cholangitis. And obviously they might have had some gallstones at the bottom of it that were fueling the infection. So the answer to that is, and I don't think that in this day and age that you need to do hepaticojejunostomies for choledochal lithiasis. You should be able to solve that problem. There might be the odd patient in a specialized unit, but generally that's not something that one would do routinely and substitute it for a choledochoduodenostomy. Those are, I think, outmoded operations generally for choledochal lithiasis. You can solve it by other means. I think Ed would agree with that.
Sandie, if you can describe the operation that well, you're giving away your age.
I didn't do too many of them.
No, I can just agree with that. I think in general, it's accepted that choledochoduodenostomy is not a good operation. And
Yeah.
I remember that we looked at that when I was a registrar on patients with primary bile duct stones. And patients in whom a choledochoduodenostomy was done as opposed to a hepaticoduodenostomy, that significantly worse.
Yes.
Really, I think an operation that's in the history books. And the whole sort of risk of cholangiocarcinoma has been up and down, but I think at the moment it's accepted that it doesn't really, the operation itself is not a risk, but often if you think about patients with intrahepatic stones and cholangiopathy secondary to worm infestations, they seem to have a higher incidence of cholangiocarcinoma, and it may not be related to the operation, but to the pathology that triggered the operation.
Yes. No, I think so. And also if there's chronic biliary sepsis, after the intervention. So a narrow choledochoduodenostomy was you could possibly envisage that being there. But do you agree, generally speaking, for choledochal lithiasis, you don't even need to do hepaticojejunostomies. I know that would be the preferred operation. But by and large, we can solve most of the problems directly through the duct or with a few exceptions.
Right. Any more questions or comments from the participants? Right, Chris, are you going to conclude?
No, I just want to encourage people to please send us any case presentations that they may have. We'd be very happy to present them. You can submit them or message Karen Fenton at the foundation office. And we would really like all our colleagues in South Africa and Sub-Saharan Africa to take part. And these sessions obviously will happen every few weeks. But please, we'd really like to hear from you.
If I can just reiterate that, and also to tell you that obviously we've changed the date from Thursday to Wednesday at this slightly later time of 4:30. So that will be the routine going forward. But definitely we do want to try and move the whole thing towards individuals not from our unit presenting their clinical problems like Bongani did today. And again, sort of see what help we can give them with managing those. That's really the essence of where we want to get to with the program. I don't know if I can just say a few thank yous to everyone. Again, obviously we're indebted to India, who help us with the logistics, and to Cheryl and Karen, who pull the strings behind us and keep us on track. I'm sure they would prefer certainly me to be more efficient, but we're trying our hardest, and look forward to further interactions and with the program going forward. And I think Ed's also maybe wants to share his aspects of taking HCC forward on this platform. So I think there are exciting developments coming, but we would love to see your participation and as I say, Chris emphasized that in terms of interacting with Karen or with any of us through our emails. Thanks very much.
Ed, won't you tell us about HCC?
Yes, so the first meeting is, if I'm correct, going to be the, was it the 17th, I think? In other words, in 2 weeks' time. And it's really a meeting that is, we want to run it or hope to have it as a multidisciplinary team meeting with a short 10 to 15 minute topic that will be addressed around HCC, whether it's screening, diagnosis, surveillance, and also the different treatment modalities, and especially in the sub-Saharan context where we know there are a lot of challenges. And again, to bolster it with case reports from sub-Saharan Africa, and I've had contact with colleagues in Eastern, Central, and West Africa that are very keen to have cases discussed in these meetings. We're just still working on the logistics a bit because showing imaging can be a little bit challenging, but we also seem to have solved that problem. So the first meeting, as I said, scheduled for today in 2 weeks' time.
Well, thanks, Ed. Thanks, Sandie. Thank you, everyone. And that concludes the session. Goodbye, everyone.
Thank you. Bye-bye.